But I'm Matthew Tolliver. I'm a director of behavioral health in the Department of Pediatrics at East Tennessee State University in Johnson City, Tennessee, and work as a behavioral health consultant there. And I co-chair the SIG with Chus, and I'll let you just introduce yourself.
Hey, hi everyone. Welcome all of you, especially the new people. We hope you continue coming. We love seeing new faces. So I'm a co-chair of this group together with Matt, and I am an integration manager for the PPOC, Pediatric Physician Organization at Boston Children's. So that's my introduction. Let's move on.
We have other members of just our leadership team here too that help out behind the scenes and during our calls. So Rachel Petz is on the call, Cody, Michelle. So we have Jonathan and Jackie all try to help coordinate the project. So Chus, I didn't know if you wanted to discuss a little bit about our theme for today, and we can get started. I think we're mainly trying to have like a facilitated discussion and a little bit of a research topic on a theme.
Yes, so we were trying to align this is how we do it portion of this meeting, which is one of the regular pieces that we do, together with the research corner, that is the other piece that is also an integral part of the meeting. So for this one, we decided to touch on the bridge care. In pediatric primary care, everyone is getting overwhelmed. And we are, all of us, noticing the crisis. And we often bridge care to nowhere. So that's the reason why we decided to title that this portion for today. So we would be interested in hearing from everyone. Not only has that changed the way you practice because of what you have to bridge, and also how do you tackle the issue of not having available services. We welcome any creative ideas as well on how is this something that needs to be addressed as a team. So any ideas that you might have, or questions, or anything that contributes to the dialogue. And as Matt was saying at the beginning, this is a very informal group, so we encourage everyone with an idea, even if it's not formed, to just throw it out there for the discussion.
Yeah, thanks. And I think this is a problem that's been occurring even before the pandemic, but the pandemic's probably worsened things where, if you're, no matter what setting you're working in, you may be in a position where you're having to refer people out into the community mental health, right? Or maybe you're in a position where you're actually working in community mental health. But if you're not, at least for me, I have this challenge of, I'm in primary care, and I get kids who are have pretty severe concerns, or might be a complex case, and kind of thinking about how do you make these decisions about when to kind of refer out, right? And what criteria do you all go by for that? And because I think sometimes for us, even if we want to connect them to our community mental health system, might be 6 weeks before you get an intake. And then they don't show up for the intake, or they show up and then don't come back, or they show up, come back, and go for 2 or 3 times and then fall out, right? So it kind of feels like this bridge to nowhere sometimes that Chus was mentioning. And so we want to just, I think, get your general reactions to that. Maybe it's just us that feel that way, but what are other people's experiences in terms of trying to connect people to maybe higher levels of service? What barriers do you come up against, and what creative solutions have you encountered?
And if you don't have the problem, please let us know how that happens.
Hi, Jessica Connor in upstate New York. Yeah, I have this problem just every day, and it's my team is just myself and one other BHC, and we talk about it every week when we meet. A couple different strategies that we try. One is to like talk with families about like reaching out sooner rather than later. And so like for folks who we meet and are right away like, this person is likely to benefit from and likely to engage in therapy for that subset of people, which is by and far not everyone, but for that subset of people, we start talking right away about getting connected. I have the intake packet for our county mental health clinic, which will like take all of insurances. So I like print out the packet for them and I hand them the packet and say, okay, start filling this out. And I made a cover sheet that like has the instructions for it. So I try and just like break down as many steps to it as I can. And then every time they come in for a follow-up visit, I ask them, okay, like, have we gotten a chance to fill that out? Have we submitted it? And just kind of stay pretty monotonous on it. Lately, I've been really excited to be a part of, like, we've had some different community level meetings where like I've gotten a chance to talk with like some like superintendents and like the leadership at our like county mental health and some of our bigger private practices and like the substance use team, and we're starting to have these more like community level discussions, which have not yet materialized helpful things, but at least we're having discussions of like stepped levels of care, and like just because someone is in therapy doesn't mean they need to be in therapy forever, and they can step down from therapy to BHC support, and that's fine. And so taking kind of a team-based approach and expanding the team has been the way that I have maintained sanity, but it's a rocky boat.
I think that's so important to be able to like start building those connections, you know, from like a systems level to help solve some of these challenges. We at our clinic, we met with the clinical operations folks, you know, in the community mental health center and set up kind of this dedicated referral line. So beforehand, patients would have to call like on a Monday between 8 and 8:30 to this community mental health center. And, you know, you had to be holding your head just right to like get them to answer. And like, if you didn't have, you know, if they didn't have an availability, you had to call back again the next day at a certain time. And it was just a lot of barriers for patients to access. And so that was one reason they gave up. And so they created this dedicated referral line where when someone wants an outpatient referral, as the BHC, I can call that line and give, you know, that organization, they have somebody staffing it, you know, I can give them the name, birth date, reason for referral, insurance type. They take that and then they reach out to the family and offer an intake from there instead of the patient having to like, you know, figure out that whole system. And so that's been one way that we've tried to reduce, you know, the barrier a little bit. That's a great, you know, a great thing, I think, to start meeting with those people and trying to form those partnerships. What about for other folks? Oh, okay. Cody, do you want to talk a little bit about like the stepped care model that you all have tried to set up?
Yeah, so we have a few different steps within our model. The first step being kind of consulting with PCPs, not directly seeing the patients, and then kind of seeing the patients on the primary care doctor's schedule, which is predominantly done by the psychologist on our team. And then psychologists do some really brief, sometimes we call them boot camps, but kind of like 3 to 5 sessions on our own schedule, at least ideally, that's what we're supposed to be doing. And then we have co-located therapists who are typically master's level folks who are seeing patients for kind of a course of CBT, so like 12 sessions or something like that. And then if they're not making progress at that level, or maybe they presented with something really severe and intractable and they've been in years and years of therapy and nothing has worked, we do refer out immediately. You know, one of the things that's been really hard for us is determining criteria for which step you belong at, because we have kids who are coming in with 24s on the PHQ-9 and extreme comorbidities and suicidality who do really great with some consultation during SSRI checks, and they do awesome. And then we have some kids who are, you know, an 11 on the PHQ-9, and they just seem to continue to grind and get worse over time. And so we're really having a hard time identifying variables that allow us to say, you need specialty care, you need to stay in-house, here's how we work it up, other than just putting them through the levels and saying, how do you do? The only problem with doing that is then once you put them through all those levels and you put a referral to specialty mental health, it can still be like 6 months, 7 months of a wait. And so now we've kind of exhausted all of our resources in-house and still have to wait 7 months after we found out that what we're doing isn't working. And so we're trying to really figure out kind of how to put each people in each step, or maybe just continuing to work them through each step. One of the things that we really try to focus on is not about who we see and who we don't see, but what is our scope of practice, right? So we see everybody. It doesn't matter what you're struggling with, but the scope of what we do with you is going to be what it is, and trying not to do, like sometimes we say, trying not to do surgery in primary care, right? Our primary care docs aren't doing surgery in the exam room because there's the long wait for the surgeon, right? They just don't do that because we're not set up, we're not equipped, we don't have the tools, we don't have the time. And so we try to do that too. That's kind of like a phrase that we throw around. Are we trying to do surgery here, or are we really being an outpatient person? And how do we do the best primary care level of service that we can at this step without trying to overstep what we can do or overpromise what we can do to the families too? That was kind of disorganized, but hopefully some of that was helpful.
Cody, I have a question for you, because I mean, I wrote down all of that, and I'm about to transition into a new clinic where, I mean, I've been working with these providers, but I haven't really talked about like the scope of practice, right? And I find that without that conversation, trying to sell the stepwise model is really hard, right? Because they just haven't lived it yet, right? It's just like hard to get. What were some of the key talking points that you felt when you're working with providers, medical providers, or your partners, and or even people who get hired on the medical side, and you're talking about this model and not what you do versus don't do, but that stepwise approach to your scope? What have been some key phrases or coined terms that you found to like sell that service well?
Yeah, that's a really awesome question.
Sorry, friend.
No, it's all right. It's a good one. I like it. I was actually just looking because I see Noelle's on here, and I'm hoping she can jump in. She's a former fellow and attending here, who might have some more recent conversations, because she's actually started a clinic since I have, 2 of them actually. And so I would say the big things for me is about having a shared mental model about what we're trying to achieve from the outset. And so I like what you're saying as far as having those conversations now, because if you wait until you're providing clinical services down the road, it can be harder to have that conversation. But if we all agree on what I'm here to do ahead of time, it can be really helpful. And what I really say is like, what do you want my help with? Because there's kind of 2 things that we have to figure out. What is the reach of my services in your clinic? Like, what percentage of your patients do you want me to see? Do you want me to only see a couple of your most severe patients? Or are you hoping that, just like a regular primary care provider, I'm reaching most of the patients and we're getting most kids better and only sending those who need the severe stuff out? And then what is the scope of services you want me to provide? Do you want me to just help you screen and refer out? Do you want me to screen and then do some joint visits so we can really maximize what's going on your schedule? Or do you want me to follow up briefly with some folks and then I can see a bunch of people? Or do you really want me to just focus on those couple severe kids that you have as part of your clinic? And then we can kind of negotiate and hash it out from there. But doing that up front, I think is super important. You know, one of the things that I think was really helpful for us is to differentiate a therapist from a consultant, and to really define our role as a consultant and how that's different than a therapist. You know, I think Matthew's research, Matthew, did you look at this on your dissertation? It basically showed like most medical attendings don't really know the difference between all the different types of therapists. Right? So we're talking like years and years of difference of training, let alone the different types of therapies, right? And then on top of that, you're now adding consultant versus all the different kinds of therapies and all the different kinds of therapists. And so it does require a lot of training and conversations, I think, up front. So the first thing is, am I a consultant that I'm really helping maximize what primary care does? Or am I a referral source and a therapist? And if your model has already defined that, then I think it's just important to educate them on what that is. And if it hasn't defined that, then I think you just have to have that negotiation up front. And I would try to get that sorted as early as possible.
Cody, I have a question. So considering you have sort of both, like we do actually, like in some of our practices, what is the ratio of the outpatient-like clinicians to the consultant? How do you manage to keep access for those who take the patients in an outpatient model?
For like the master's level folks who are doing co-located therapy?
Yes.
Yeah, I think we just, I mean, sometimes there's waits and sometimes, I mean, we do an okay job at moving people through. I think the biggest thing is like we talk to families up front about what this is, and we try to define our treatment targets ahead of time. And we say, you know, at session 5, we're going to check in to see if this is working. And if it's not working, we're not just going to continue to do things that don't work. I think the Monroe Meyer group had published a paper. Actually, I think it was some people on this call. Saveki, you might, Jess, you might have been on that paper. It basically showed like in co-located therapy, you tend to make most of your progress by session 5. And then after session 5, you get very limited returns on continuing to do intervention, right? And so one of the things that we try to do is stop at that session 5 and say, is this actually moving the needle? And how much more benefit are we going to get by continuing this? And kind of moving patients out to specialty care at that point, or stopping treatments and having those kind of direct conversations and defining what success is up front, I think has been helpful, because then we're not holding on to people forever. The other thing is we don't take referrals for supportive therapy. And I think that's been really helpful, unless it's defined as that. And we define the number of like supportive sessions, right? Because a lot of times parents will be like, I just want my kid to have somebody to talk to for the rest of their childhood. And I'm like, that doesn't end, right? We can't take that. We're more skills focused than that. And so we tend to send those referrals to the community too, which does help. And again, same with providers. I think when we have those conversations with patients up front so that they know what they're consenting into, it's almost relieving for them, because people aren't as upfront as that with them. And they'll just say, sure, I'll take your money and see however much you want to take. But I think they're really relieved when they have some education around the different levels of services. My dream is, and we haven't created it yet, is I want a handout that's like consultants, boot camps, and like co-located therapy. Like it just kind of breaks it down. Maybe that's it. Maybe it's like consultant, co-located therapy, and then community or more intensive or outpatient or specialty or something like that to really walk patients through that.
Yeah, we brings us back to the algorithm. What are the criteria? Does anyone have any ideas on that?
I have some thoughts on this. My name is Louise Chan. I'm a psychologist at Pediatric Associates in Columbus with Cody. Hey, Cody. We have a model where we sort of do the middle of what Cody described. We have one BHC who's able to provide either that brief or up to about 8 visits. So sort of a hybrid. But there are a couple things we've really thought a lot about. One of which is this idea of bridging without communicating you're too severe for me, so you're too much for me to handle. And so we think a lot about and talk a lot about how can we communicate to families, it's not that you're too much for me or you're too much for this setting, it's you need something different than what we provide in-house. We provide this really targeted, brief, solutions-focused therapy. We don't do weekly talk therapy is sometimes the lingo we'll use. And what I found in those discussions is family preference really is so key to pull into that discussion, because I have a lot of families where, yeah, I really think they could benefit from longer term therapy, but they don't want that. They want sort of the good enough. They want some ideas about where to kind of move them in the right direction. And if we're on the same page with that from the front end of, hey, this is what I can provide, and here are the outcomes I think we might be able to achieve in that amount of time. I think when we can kind of come on the same page and take in those patient preferences, it goes a long way. Because we have a lot of families where we do end up referring for longer term therapy, and like you said, either don't follow up, or they don't show up, or they don't like the clinician. And so they can always pop back in. And, I'm just really clear. What I can provide is a little bit more guidance on what to do next, and maybe a few more visits to kind of give you some boosters on what we already worked on. What I can't do is that weekly longer term therapy and doing some problem solving around that. So I feel like this idea about how we communicate bridging to something different versus something that's necessarily higher level can be helpful in taking into account patient preferences about the type of treatment or sort of the intensity of treatment. Some families really right now in their schedules can only manage 2 or 3 visits, and maybe that's kind of good enough for now.
I think, that's so important. And I think at least in our setting, probably one of the most neglected aspects that goes into the equation when you think about criteria for a referral, right? Like, I think like in the students that I supervise, to a lot of times it's like, well, they need outpatient therapy because of the severity of their concerns and, the level of their impairment and how long this has gone on. But it's like, if they don't want that and they're not willing to go and they can't organize their life around that, then what we're providing in primary care is what the services they're going to be getting, even if in an ideal world, they would and could access a higher level of care. And so I tend to not refer folks out kind of at the first session most of the time, because I feel like if you can't come to see me for kind of 30-minute flexible, as needed sessions, if like you can't organize your life to do that, that's a little bit of a proxy for like probably not being able to follow up in a longer term setting too. So, but I'll try to have that conversation from the first session of just like that difference between what I do versus outpatient therapy, and then kind of plant the seed even from that first visit of, hey, if we get to this, if we meet 4 or 5 times and you feel like we're building momentum, but you just really want this on a regular basis, or, you're realizing that you want something different, that's like our check-in point kind of. And I think, Cody, it is hard though, if you have to wait months to access that other service. I think we're probably about 4 to 6 weeks for us, for our connecting the community. But I just am so glad you said that, Louise, because I think that's a really important component that we should all integrate into like that decision about whether to refer out or not.
I'm curious to know, for those of you that are doing this more stepwise approach, I always have so much heartburn, I guess, when it comes around risk management. As we're all seeing, right, kids have a lot of, the acuity is a lot higher when it comes to suicidal ideation and non-suicidal self-injury of recent. And, I may consent for service by saying, okay, we're going to do like 5 to 7, 30-minute sessions. We're going to monitor your progress every session. If we're spinning our wheels, we'll definitely talk about a higher level of care. So weekly, hour-long sessions with someone in the community, because at this time we don't have anybody in-house that can do that. I find one of 2 things tends to happen. One, they either don't follow through on making calls for that referral. And so session 7 comes and they're without another, a plan for follow-up, or the wait is so long and their risk acuity is still high where I have a hard time sleeping at night. Even though we have a safety plan, and even though across those 7 sessions they haven't done anything to hurt themselves, I'm still kind of like, well, what if, right? So then I feel like the 7th session becomes arbitrary, but then the cycle repeats itself, because they're like, well, if we have you, why do we need this other service? So I'm curious, like, are there people on this call that have navigated that challenge, and what's worked really well and what's crashed and burned? Because I feel like that's a huge sticking point right now for us. And if it's a sticking point for everybody else too on this call, then we need to have more meetings where we just drink tea and listen to calming music together.
I love that idea. No, it is tricky. It is tricky. I would say that the couple ways that we manage it, one is that we are very fortunate to have primary care leadership who understands the team-based approach. And so many of those patients are not coming back on our schedule. They're actually coming back on the PCP schedule. We're training them how to manage it and consulting and checking in when they're here. And so it's not really about whether or not that work happens in our model. It's about how that work happens. And it's kind of staying true to our scope. If our scope is consultants to them and that they retain most of the care, then we're consulting during those visits and supporting them. But we also have some structures that allow us to do that and to be able to bill for those visits routinely and regularly as well. And so that would be one thing, is I would say it's not about whether they get follow-up or don't get follow-up. It's just about how that happens. And oftentimes our system and our leaders in our primary care system see this as a primary care problem, and that we need to address this and deal with it as a team. So at least I'm not the only one who's up at night not able to sleep when we're following this patient, and it allows availability and doesn't kind of backfill my schedule too much. And a lot of times, if we're really that worried about acute suicidality for a long enough period of time, we want them on an SSRI anyway. And so there's a good, or at least we'll be having conversations about that, or we'll at least want the ability to prescribe when they're there, and which is our rationale for bringing them back on the medical provider schedule. That if this kid is so severe that I need to keep them on my schedule for longer than our model dictates, we need to have the flexibility to be able to respond quickly to an SSRI if and when it's needed. We're often monitoring weight or labs or other things as well that the PCP can be involved in. And so we just kind of differentiate our roles. The other thing is the language we use around referrals. So we don't say referrals, referring out, those kind of things. We say we need to add a specialist to our team. And that has been really helpful to our families. This is what I can do. This is my lane, and I can't go beyond my lane. And we need to add a specialist to our team. Just like if your kid were to be diagnosed with diabetes, we would want to add an endocrinologist to our primary care team. But that doesn't mean that I'm no longer your PCP just because now you have an endocrinologist. And same thing for this, we've diagnosed conduct disorder or PTSD or whatever it is. We now need to bring a specialist onto our team that is not subtracting me, that is adding somebody to our team. I still want to check in during your med checks or during your well checks, or heck, some patients I'll even see just as a consultant to check in quarterly, even though they're in regular therapy, as a way to bridge and communicate with the PCP about what's going on with that family. So it's not about me or them. It's about, can we add somebody to our team? And then we're just clear with them about the limitations. Like, I know it's really hard. I know linking is hard. And we wouldn't really expect to see that improvement that you're seeking until we get that connection we add that person to our team, because that's kind of what their job is on the team. And so that's been a little bit helpful too.
When I hear you talk, I see how strong you go on the definition of what you do, and that's how you build the rest of your response. So you never hesitate on that. It's kind of nothing shakes that in your team. So I wonder, the rest of us who are questioning the model, hearing you, it makes us, at least for me, go back to say, okay, we have to get our army stronger instead of trying to, revisit what we do, or perhaps do something different in the community because it's harder. But I wonder, on that other end, is anyone doing something that works for collaborations with the community when you don't have those specialty care within your program? How are people managing longer bridging roles, and how do you do it? I think it's the wrong question.
Hi, I'm Ali from New Jersey, and I started working at Summit Health just a couple months ago. So the whole integrated behavioral model was like very new to me. So at Summit Health, prime time, like after school hours for kids, it's really tough to come by those time frames. And and I agree with Louise, like really finding out like what's the parents' preference. Do they want in person? Do they want telehealth? And really like navigating that. So in New Jersey, we have Perform Care. I don't know if that's like available in other states, where they offer like in-home services for children with any kind of behavioral challenges. So sometimes we utilize that service. I do therapy as well to bridge that gap, but I can't treat every disorder. So we also have this platform where we can make referrals. I don't know if anyone's heard about it, like Alma or Ray or Quartet. Those are like really, really helpful with getting children like therapists right away. And it's almost like a table, like, you know how like when you go to a restaurant and you put in like, oh, this is the time that I'm available, this therapist. So they arrange with a therapist that really works with that specific specialty, whether it be an eating disorder for that child, any kind of Asperger's or communication disorders, really navigating that way. So, you know, that's what like we've been using, but there are a lot of challenges, a lot of wait times. And, you know, I'm a parent as well. So it's just like, if it were my child, I'd be like, oh my goodness, can we get anything sooner than later? And so we are definitely finding like those variables right now, those challenges. So I just wanted to share.
Yeah, thank you so much, Saida. How do you pronounce your name? Alide or Alide?
Alide.
I think another thing that comes up, you know, it's not just how do you get people connected to the community, but at least in our practice, we have a lot of people who are fully connected with the community mental health system, who then are coming back into our clinic saying my needs aren't getting met, right? Or my therapist can only see me once every 5 or 6 weeks, and you know, I was able to get in with you today, right? And so I don't know if other people who are in a primary care or another a non-community mental health setting address that, but I just try to help as an intervention almost, talk to families about how do you advocate, you know, within that organization to get kind of the needs met that you have. Sometimes it's like, well, I didn't connect with my therapist, and so I just dropped out, right? So how do you help families know how to, because this is a whole system, right? Just like the school system, healthcare system, the behavioral mental health system, kind of giving those tools for navigating that kind of system, and how to, you know, if it's not working and you need more help, like helping instead of taking that case on and just you know, seeing them myself, I try to help them navigate the system they're already in. But I didn't know if other people are experiencing that, or what your approach usually is.
I agree with that. You know, we have a little framed poster in our team room that says to like focus on the problem solving mechanism rather than the problem itself. And I think that kind of fits in there, where I think my first thought is, okay, what's kind of breaking down in terms of the family's ability to, like I said, advocate for yourself, or, you know, what is the kind of way in which I'd be kind of expecting them to solve the problem that maybe is kind of not exactly connecting right now.
I love how you put that, Joe. I was wondering when I was hearing Matt, and also with your comment, Joy, that I wonder if this conversation is taking place in the community agencies, parallel as we have this discussion, and how often or not we have those conversations together, because I bet they are also talking about not having access for the kids that we're trying to place there. And I believe that we are not cross-fertilizing a lot of each other. And that could be one way we could start having different conversations about that problem solving that you're talking about.
Has anyone had success at like getting therapists to send their notes to the primary care doc if they're not like embedded within the same system? Because like, I'll talk to different therapists and they'll be like, oh yeah, like it's great that you all do medications. And like, they seem kind of surprised that we like know a lot about the kids. Like, I think that like when you're in a specialty mental health setting, like you do get this kind of like tunnel vision and you're like, I'm the only one who knows this kid and I know them best and I'm going to know them forever. But then it's like, okay, well, you saw them for maybe a year or two, but we're going to see them for 21 years. Just like my rant, because I lose my mind sometimes. But I try and talk them into like, hey, if you're telling this kid to like come here to be evaluated for a medication, like, could you give us a call? Could you send us a note? Like, we want to know what you think. Like, I try and put a lot of like we really value your input. Like, we think you're doing an awesome job with this kid. We know you're seeing this kid weekly. What an awesome job. Like, what do you think about this kid? But I cannot convince anyone to send me their notes. And then we just end up in this phone tag hell that doesn't get us anywhere either. So I don't know if anyone has successfully talked specialty mental health folks into document sharing.
We haven't had a lot of success either, but I just kind of assume they're probably facing this same crisis that we are, right? And they're probably having double the caseload that they usually have, and all sorts of things. It can be difficult. But I think sometimes it takes like the leadership of those different organizations to be able to even, create systems to kind of filter down for that. We tried for like a year to get one of the specialty mental health therapists access to our electronic health record, and vice versa, so that we could read each other's notes in our own records. And like, it just couldn't happen. It just never happened because of all of the issues legally with it. But it would be so nice if we could have just all have the same electronic health record, right? I did want to check in with Rachel. I didn't know, Rachel, is there a particular article this month that you found, or should we just continue our general facilitated discussion?
I'm open. I do have an article to share related to system navigation, which you all have kind of talked about, maybe being de facto system navigators for your clients or your patients. But I'm happy to hold off on that, or whatever we feel like makes sense.
Why don't you go for it? Because I think it's in line with what we've been talking about, and then we can just talk more after that.
Absolutely. All right, I'm gonna share my screen here. Hold on. So I wanted to present more of maybe a potential solution. Obviously, there's so many different variables here as we think about bridging that care, or kind of that bridge to nowhere within the community. And this is more focusing on if you do decide to kind of make that referral, or you're really trying to help families access care, you've made that decision and had that discussion, and how do you kind of help facilitate that? And so I'm going to present kind of a model of doing so. One way to help kind of bridge that gap, and that is, they're called system navigation models. Some have called them patient navigation, family system. There's kind of different names of doing so, and they function as they sound. They are individuals trained to help families essentially navigate the health system for all of the barriers that we've already discussed thus far. And I think the real idea is, the ultimate goal is to help families really establish care wherever you're referring out, and of course, maintaining care once we get those families in there. Cool thing about navigation models as a solution, it can be clinician led. So you can have professionals, it could be us, right? It could be BHCs potentially, but it could also be peers and community members. So it doesn't have to be kind of highly trained clinicians doing this work, and we probably don't have a whole lot of time to do this work anyway. The peer kind of community-led piece of this that's really cool, it helps families, first off, if they have similar backgrounds or maybe similar lived experiences related to the presenting problem or the healthcare system. So examples would be, you have a family who previously, perhaps a parent, navigated the health system and getting a autism spectrum or developmental kind of diagnosis or assessment. And that's kind of one example where this has been used. And so it's cool because it's the family members who've gone through this before. So it lends a different kind of credibility and potential way to kind of support families. It's not just kind of top down. The idea is it's going to help both the structural pieces that we've talked about in terms of time, transportation, costs, financial. So navigators can help with the structural piece. but also potentially the perceptual piece of barriers to care, stigma, attitudes towards services, maybe beliefs that, what they're getting, they're not going to be helpful, or things are not as big of a problem, et cetera. So it's kind of ideal and potentially can be used in either way in terms of helping families. So in terms of different services provided, there's many different ways that you can implement navigation. This is coming from an article that essentially kind of put forth, hey, we need to have system navigation in primary care for behavioral health services. So it's kind of like a position paper that was arguing for the need for this. I guess a kind of side point, that a lot of the system navigation had been used with more, actually started in cancer clinics, and helping patients access treatments and navigating when you have more kind of complex health needs. So position is that we can do this for behavioral health care and we need it too. So different components, it could be psychoeducational, right? Like talking to families about child development or the presenting a problem, why it's important to go access services and get treatment. It could be providing emotional support, that instrumental piece in terms of resources and following up. It could be advocacy in terms of getting the care. So there's lots of different ways that navigation can be presented, or the services can be provided. So evidence, I'm actually going to present a review paper that my colleagues and I completed last year. And essentially what we were doing is we wanted to review both implementation and service use outcomes of system navigation models. And we were focused on behavioral health services, but it was pediatric settings, broadly speaking. Mostly because, as you'll see, there's not that much in terms of primary care. So we looked at, is there system navigation in primary care, specialty clinics, schools, community settings, et cetera. And we're interested in what did people do, and did it increase, did it get people to, whatever the service was? Did it help maintain, keep them in service? So there's not a really robust literature here. We only found 8 studies that could be included. And here were some of the characteristics of those studies. I'll just kind of place them up here. Ranged from toddlers all the way to adolescents. Interestingly, half of the studies focused on developmental diagnostic assessment. So there's kind of this niche area that's focused on autism spectrum disorder diagnosis. And obviously there's kind of different aspects that go into that kind of more complicated, complex assessment and multiple appointments and things that need to kind of go into that. So it's interesting that there's kind of targeted towards that. And then half of the studies looked at just behavioral health services, broadly speaking. So it could be access to treatment or other assessments, et cetera. The majority of the navigators were in specialty care, which I think related to some of these developmental clinics, that there's other kind of specialty clinics looking at ASD. We had some take place in primary care, also schools, some in community mental health. Half and half split in terms of professionally trained navigators and some community or peer led. And in terms of what they did, or how they kind of implemented the services, most of them, I mean, there's a broad range. It could be, we give you a few phone calls and we kind of make sure that you follow up with the referral, or it could be kind of in person, let's talk about barriers to care. So they can kind of provided a little bit of both. And in terms of getting into some of the services offered, it was really difficult to quantify because it quite a broad range of, what did a navigator do? So related to some of the things that, discussed previously, some of it would be just described broadly as we're providing emotional social support. Sometimes they were a little bit more specific in that we had a motivational interviewing type of conversation with a family member about getting to their appointment. Sometimes it's just talking about, why do you need this assessment? Why were these recommendations made to you by the provider? What's the importance of following up? Obviously, the kind of very structural piece of what's stopping you from getting to your appointment. Let's come up with a plan for overcoming that. It could be linking families more directly with other services above and beyond, if there's issues with transportation or there are other kind of social services we can provide for this family. It's a very, very broad range of what a navigator could do. As I mentioned, we're really interested in the service outcomes. So like, did people show up more often if you got navigator services? And we can say that in a kind of, a preliminary way. If we look at the studies and we kind of summarize them in a more descriptive way, yes, people who got navigation services were more likely to complete those diagnostic assessments and received an increased dosage. So it could be minutes. Some of them were quantified by minutes, or number of kind of sessions completed. And we thought it was noteworthy that this was found. General positive finding, of course, in most studies, and there's really broad range of patient populations and settings. So I thought it was potentially generalizable. Obviously, implemented in primary care can be used in this setting. So thinking a little bit about future directions, maybe this is one solution to the bridge to nowhere. If you have the ability to hire and train these navigators. And so we could talk a little bit about pros and cons, or if you've served in that navigator role yourself, or if you have people that kind of social work that maybe does more of the kind of advocacy type of role versus kind of treatment implementation or service provider. And Matt acknowledged the NIH actually funds this work. It's really cool. And we can share this link for you in the chat if you're really interested. I think people are kind of seeing this as a way to really help bridge care. So I'll open it up to people in terms of thoughts, and didn't check the chat here.
We got lots of ideas going in the chat.
Yeah.
I was wondering, are these navigators usually managing registries of patients and more like doing like formal case management where it's like, hey, if you haven't shown up in this many times, I'm gonna reach out, or are they using them more as like via warm handoffs? Like, okay, in the moment this concern comes up, let me go in, and it actually would model more of like BHC work, but except it's a different scope. But then, I wondered how much tracking and follow-up those navigators typically did.
That's a good question. I'd have to look back to see how they do that. I do remember though, there were some models that were kind of like the warm handoff model. In fact, the primary care, one of two primary care studies did describe it in that way, right? That they were there was an identified need, and we're trying to make this referral. We want someone to come in, and it was same day, kind of help them navigate and figure things out. But that's a good question about like, how did they know? Like who, how are they tracking and making sure that I'd have to kind of look back and see if they describe to that extent in the studies.
I have two quick questions. I think this is a great idea. Did the article talk at all about how this may or may not be different from care coordination in that role? And any thoughts from the article or anyone else on how something like this would get paid for?
Yeah, that's a good point about care coordination. There's lots of overlap, and be kind of curious to kind of think about how we might define them differently. And I know one of the unique aspects of navigators are sometimes employing people who aren't professionals and are simply just people who have experience and lived experience. I think makes it unique in some way, but certainly has overlap. Now, in terms of paying for it, that's certainly a different story. And I think some of these studies were grant funded, right? So it's like, you get funding for a period of time, but may not be sustainable. And I know that NIH grant is probably part of that. But I don't know as much in terms of kind of maybe more of the sustainable aspects of funding this. It's a good question.
I wonder if, to the extent it helps these larger health organizations meet certain like valued targets for insurance companies and stuff, maybe maybe some of the costs could be justified through that. Like, hey, if we're actually able to manage our kids' asthma or their diabetes really well, we get extra money to show that we're doing that well. And if these people are kind of the key to that, maybe that could be one way to sell it.
Yeah, I agree. It's hard because it's definitely a term investment, right? So even with integrated primary care, I feel like we sometimes have to be careful in how we talk to payers because, 18% of kids nationally who are referred after being identified in primary care ever get an appointment. And, 97% of those kids are getting seen same day in our model, which means payers are now paying for 97% of referrals instead of 18% of referrals, which is a massive cost increase for them. And then if they're getting more care, they're now paying for all those additional services. And so we have to have some pretty massive savings on the other end. If it's only about kind of saving money in the long run, it can be really hard to demonstrate that because we do such a good job of increasing access, but payers will often say access is more bills that then have to be paid.
It seems like there might be an opportunity at the physician level to demonstrate that this would reduce stress on their role if their kids are getting better taken care of. I agree though with the insurance panels, this might be hard to sell that through insurance.
It's hard because like nobody asked the front desk staff to make up their salary, right? Like, or the referral staff or anybody else. And so I don't know, to the extent that something like this, I see, I don't know about this role particularly, but something around like somebody who's going to address social determinants of health, do care navigation, do case management. That's just an essential part in my mind, just as much as a referrals clerk in our clinics.
I have a question because at some level, the care coordination that we are talking about is optimally done by a clinician. Like you're saying, Cody, you do a lot of that in a way that is the connection with the other clinical person. And I have heard people advocating for the BHCs to have the hybrid role of coordination and clinician versus other people who advocate for making having the BHCs work at the top of their licenses. Do you guys have an opinion on that, preference?
I think you're probably getting a lot of silence, Juice, because we're all thinking about it. And also, yeah, well, and also because I think that the reality of what it is that we do is probably different than what we would say our preference would be. I don't know if that's true for everyone else and thoughts that you're having, but I mean, that's a thought that I have is I would like to be working to the top of my license all of the time. And I'm doing all of the things that Cody mentioned, right? Like, and some of the things that other people mentioned, I think Kelly mentioned something about scheduling phone calls to do these back and forths. I do that all of the time. And some of this family navigator role, I mean, I think that we step in and do whatever is needed in order to help the families, which is also a part of my job that I love. But I do think it's challenging for everyone to have kind of right role and then right responsibilities for that, because there's so many care gaps in the way that a fee-for-service system is run.
You're kind of answering the question, right, Ali? For you, philosophically, it would be working at the top of your license. So the fact that you do it is based on need, not on what you think the role should be.
Yeah, can I bill for a few more patients if I'm not on the phone with schools and these other people so much that would eventually help pay for or reduce the cost of that other person would probably internally, in our community practices where's the bottom line that has to be met. I think thinking creatively about some of that stuff too, and focusing on the things that we can do and that we do well and what does get reimbursed. It can be hard, I feel like that's the pinch point a lot of times is our burnout comes from trying to do the role of 3 or 4 different team members, or even trying to run 3 different models at the same time. We're trying to run a PCBH model and a co-located model and a specialty behavioral health model at the same time. And then that's when we really start to burn out, because those are all separate jobs and separate roles, and it makes it incredibly stressful. And there's also some moral injury and guilt that comes with deciding to not do that any longer, because the patients are the ones who end up suffering. So it's pretty tough.
I do think there's a piece of this too that we've been exploring here, just in our well, in our clinic and in pediatrics as a whole across our system about people working up to the tops of their license. And so some of the things that we've been talking about actually really aligns with this patient navigator piece that they're starting to ask nursing staff to do. And a lot of that has come out of, so there's one BHC, there's multiple nurses, how can we really leverage their skill set as well as we are leveraging our skill set to do each of these roles. So I think that there's sort of multiple avenues that this could go down. I love the idea of it being other patients or community members doing this. And I think the sustainability part of that is a challenge.
And I think the last thing I'll say is if you live close to, you know, a university or something like that, leveraging students sometimes you can use this role. Like we have what we call our resource team, and it's first year master's level social workers who get paired up with the BHC. And so whenever they do a visit, all of that stuff kind of gets taken out of that visit that person's able, you know, that resource team person is able to take on and then follow up with. And the days that those folks are in clinic, it makes my life a lot easier and I'm a higher level of job satisfaction. And but they require supervision too, and you know, but I think that's just another potential route that you don't have to pay for. You know, if you're already running a training program, for example, it's pretty easy to kind of just build them into it as well. Well, I think we're at 1 o'clock, but it's so great to, I'm glad we had great attendance today. It's so good to see everybody, and thanks for the thoughtful discussion. And Rachel, thanks so much for pulling that article. I thought that was that's perfect to really summarize up everybody's talking points and things about some ideas for the future. Anything else, Chus, that we should mention?
No, thank you, Rachel, as always. I love your summary of the articles, and especially this one that was done by you.
Yeah.
It'll be easier.
Yeah.
Yeah. All right.
All right. Well, we'll see y'all next month.
Thanks.
Bye, everyone.